Great, thank you so much. I may go quickly through some of my slides for the sake of time. These are my disclosures. So, what we see in the real world is very different than what we see in the textbooks. And so not every patient really follows the rules of exactly a nice P2 prolapse or a big FMR, atrial fib FMR. And these are the guidelines for a DMR, and I'll just refer to them and not go through them in detail. And of course, these are the guidelines for FMR. And there's been a more simplistic thing that Thourani has put together. And we'll go through some of these and how we make decisions. And I brought in 4 different patients that we'll go through. But a lot of it has to do with the risk stratification and anatomical assessment. I think that's very important because at the end of the day, there are 3 different therapies: surgery, catheter-based, or medical management. So it's relatively simple. So if we talk about risk stratification, there's an STS score that we all look at. And there's obviously some issues with the STS score, but it's something that we start with. We also look at frailty, and we also look at the hostile or non-hostile anatomy. So for instance, a patient who has an expected survival of less than 1 year, who has an EF of less than 20%, and a large LV and a bad RV, really should have medical therapy. On the other end, if you have a really low STS score, low frailty, and very, not very hostile anatomy, then you're thinking more about surgery for that patient. And somewhere in the middle is whether you do a TEER on these patients or you do a mitral valve replacement on these patients. And we'll go through a couple of different examples. But at the end of the day, it's really interchanging between and meshing together the Venn diagrams of frailty, disability, and comorbidities. And we've gotten pretty good with this. And I'm actually lucky because I have people like Manny and Pradeep and Vivek who we sit down, and soon Jimmy, we'll sit down and look at all these patients together, to Mike's point. There are some limitations to the surgical risk scores, and everybody should just know that these different variables are not in the STS risk score, and it's important for you to understand that. Now, at the end of the day, all of our patients, almost all of our patients now who are outside the low risk, if they're low risk, they don't get this, but everybody else now gets an echo, and we very commonly will repeat the TEs. And not everybody gets a cardiac cath, depending on what they're looking at, but a lot of patients now get right, left heart caths. The thing that we've added is a CT scan. Anybody over intermediate risk will now get a TMVR CT so that we can plan for the future, and I'll show you some examples of that. To me, echo is key, and I think this is the most important part, and that's why we repeat, unfortunately, a lot of TEs. Most TEs that come from the outside hospital to us have maybe about 10 to 15 clips. We'll do about 40 to 50 clips. I can't think of an outside echo that I've gotten that has 3D echo on it. And I think, by the way, ACC has to, and other larger societies, ASC, whoever it is, needs to work on this, because I can tell you the echoes that I get from the outside hospitals are horrid. And we have, as a society, have to figure out how we're going to do a better job with that. And then you look at the other thing that we're noticing is that GDMT, unless they go to a specific heart failure, is not very good. There are a lot of FMR patients specifically who come to our hospital not even on Lasix, narcolepsy. They're not even on Lasix. I mean, forget all Entresto, and they're not even on Lasix. They're not on 20 of Lasix. And it just baffles me how people are treating these patients. So that's a different talk. But these are the things that we try to interchange on what's going to happen. Of course, one of the important things is to differentiate between primary and secondary FMR. Our toolbox has become larger and larger. And unlike TAVR, where we have almost, Mike, 10,000 randomized patients over the last 10 years, we don't have that in the mitral disease. So we're still shooting in the dark a little bit. And this is just a list of some of the toolboxes that we have. Let's present a couple of cases and think about what we would do for this patient. 80-year-old, class 2 heart failure, active, dances, probably more active than I am, but does get short of breath, has a P2 player, severe MR, EF is normal, creatinine is 1.2, PFTs are normal. Let's see if these echoes were playing earlier when we tested. You want to click on one of them? All right, Joe, what do you think? 80-year-old, very active. P2 prolapse. Why did I ask the surgeon? Pasha? Click, there you go. Now we're getting into it. Jeff? Don't say medical therapy, I swear to God, Jeff. Do not say medical therapy. Prad? Where's Prad at? Okay, no, you can't. You already spoke. You're a surgeon. You get one shot. Ah, yeah, okay. That's why he's on that side of the room. Pasha's on this side. Prad, 80-year-old dances more than you do. Wow. And I did not pay him, and he's not drunk because it's early in the morning. So these are the different ways. I did put a one-way ticket to Silverado just for you to. So this is what we ended up doing to this patient, minimally invasive mitral valve repair. So Joe, we actually put this patient in the repair MR trial. And so he was randomized to surgery, and so we did minimally invasive mitral valve surgery on him. He had a good result, no mitral regurgitation. Went home. Some surgeons got there and say, my patient went home post-op day 2. That's BS. They don't go home post-op day 2 after a pump run and having their heart cross-clamped. They do not. He went home on day 4 or 5, and he was in pain, quite honestly. And to Amy's point, he was somewhat debilitated from that. And this is just for the other. And this is for a different patient, but this is just for the cardiologist. This is our view on a minimally invasive mitral valve. This is a P2 prolapse. I won't show the whole video, but for this specific patient, it was a P2 resection, even though I usually probably do more coarsen resections, but this was a straightforward P2 resection. Cross-cant time is about, I think it was around 40, 45 minutes for this patient, and he did well and no major issues. But that's what a P2 prolapse looks like.
If you had done it robotically, you would have gone home on day 2, Vino.
Yeah. I was waiting for that, Mike. Just for the cardiologist to understand, this is a paper that was presented a couple of years ago. The number of sites in the United States that do over 100 mitral valves a year, 4. This is not per surgeon, okay? This is for the institution. The number that do more than 50 to 100, 11 sites in the country. So we can say that surgeons are great at what they do, but ain't a lot of damn people, a lot of hospitals doing a lot of mitral valve surgery. Okay, so it is dependent on where you go. To Mike's point, they do a lot of robotics, and they're probably one of the 4 sites. Okay, another. Now that everybody's awake, I may call on you, so just be careful. Don't fall asleep back there. 82-year-old female. She is on OMT. She's not on GDMT. She's on OMT. You see a couple of things there. She is breast cancer, lymphoma, socially active, lives by herself. She drives daily. And I don't know why they're not automatically working. Do you mind clicking on that for me? I'm sorry, I only have one image for this, but I'm going to show it to you anyway. Thank you. Who can I call? Amy? Where's Tom, there you are. Tom. 82-year-old. Female, mitral valve repair. I mean, you guys are exactly like it's, red and blue. Okay. Joe, agree? Okay. Pasha, agree, clip? Prod. Are you going to say clip on this one? For heaven's sake, you're abandoning you're abandoning your people. So this one got a clip. Right? And so this patient did get a tear, partly because of the active chemotherapy that she was on. And that was the big deciding factor. Somebody, 82-year-old, on active chemotherapy. I don't know if you missed that on that. That was something we shied away from a little bit. Did give her a result, and here's the result. Joe, that is not moderate MR, okay? So I just want you to know that. It can be done, not moderate, just FYI. Well, but you got to remember they're extreme surgical centers too. So I think that's going to become something that we're going to have to figure out as a country how we're going to do that. So look, I think that's mild. There's a couple of jets, but she's 82-year-old on chemotherapy. Again, it's the second pathway. Here's, of course, MitraClip. We presented this from the TBT registry. This is a slide I'm going to spend a second on. This is what we call the mitral valve universe. This is every mitral valve procedure done in the United States over this time period. So I just want to show you where things start. The number of mitral valve overall in 2021, this is a little bit annualized, 20,000 mitral valve procedures were done in the United States. This is MitraClip. MitraClip has now passed every other mitral valve procedure individually, and it started from 2014, 14,000 were done. There is a change in the mitral valve universe. 507 sites, case volumes increased. A lot of the patients are now increasing to FMR. Tear mortality is going down. I'm going to skip through some of these. There is a Pascal device that has now come out, or it will be coming out probably in the next year or so. And so here's an 84-year-old. Just for the sake of time, I'll run through this case to give you an idea. 84-year-old patient, we ended up putting into the research trial a lot of mitral regurgitation. For this patient, you can see, I think that this valve is personally repairable. Also, 84-year-old went into a research trial. We did do what we call a Pascal device in this patient. So the options are varied. The patient had one Pascal device, ended up having a second Pascal device, and you can see the final results with this, which are pretty good outcomes when it comes to mitral regurgitation. Manny, would you agree on this? And so again, different ways of doing it. Here's the patient at 1 month. And a little bit more mitral regurgitation right across the anterior leaflet there, but still we would consider an 84-year-old safe. This is the Pascal 2D trial. I want to mention 2 trials to you that are ongoing. One is a repair MR for intermediate risk patients, the primary MR, which is for low and intermediate risk patients. I'm going to present one last case quickly. Here's an 80-year-old patient, prior MI, prior PCI, CABG 8 years ago, has an AICD, persistent AFib, and objectively frail. EF is 30%, grafts are patent, PA systolic is 52, a little bit of TR, STS score is 14.5. Tom, please tell me you're not going to operate on this patient. Really? Okay. Tom said he's going to operate on this patient. There are other options, Tom, in this world. Just want you to know. Here's the echo. Joe?
Medical therapy. This patient probably will not get to us.
Okay.
This patient showed up to the surgery team. We would certainly get our medical colleagues involved.
Yep.
I think this patient certainly needs a heart-rate team to take a look and interventional cardiologist.
Brad, would your surgeons operate on this?
Not at this point. I think guideline directed therapy.
So this patient ended up having pretty good GDMT. Look at the mitral. So this is obviously not a prolapse patient. This is the gap for this patient. And I won't go through all the options and ask to raise hands, but the things that we thought about were surgical repair, surgical replacement, a clip, TMVR, and a permanent vacation to Napa. This is what we ended up doing to this patient. Again, a 4th pathway, which is transcatheter mitral valve replacement. We ended up doing a Tendyne for this patient. So this is a transapical procedure where you're able to flower this open, and you can see that no more mitral regurgitation occurs, and you have a nice deployed valve. I'm just going to have 3 or 4 slides where we talk about the different replacement techniques. There are now a lot of transeptal. This is the EOS. The previous slide showed an encircle, and here's the EOS, which is a transeptal pathway, both of these from Edwards. I think that transeptal at the end of the day will win out, but I just wanted to at least mention these, and this is just animation. We'll finish in a second. And after the transeptal is a femoral vein stick, and once these are done, the patient's recovery is instantaneous, quite honestly. And so this just releases itself and you're done with the procedure. I will mention the Abbott Sophia valve. We at Piedmont were lucky enough, Pradeep, Vivek, and I have now done the first 2 in the US, have done great. These patients, and I think we have a 3rd one coming up. So this is also another pathway. So the armamentarium for the treatment of MR has dramatically increased in those over the age of 80, which was my topic. TEER outcomes have improved. The repair and primary trials will help us define the risk categories. Ongoing TMVR trials will define the role in GDMT. This is really important. GDMT is critical for all these patients, especially in those with FMR. Thank you.